computer. Welcome to another episode of Single Payer Radio. We broadcast our program from the historic Hayburn Building in downtown Louisville. The show is a project of Kentuckians for Single Payer Healthcare, and we're an affiliate of the Kentucky chapter of Physicians for a National Health Program. We have this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, single-payer healthcare system. Everybody in, nobody out. The views and opinions expressed on our show are those of the speakers and not the station. I'm Mark McKinley. I'm a volunteer with the group. Our program can be heard on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick up our signal, you can live stream us at forwardradio.org. Mike?
Yeah, this is Michael Flynn, retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer. Any comments I make on this program represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville.
I'm Eugene Shively. I'm a retired surgeon from Campbellsville, Kentucky. The things that I say represent my personal views and not Taylor Regional Hospital in Campbellsville or the Department of Surgery at the University of Louisville.
Our topic today is going to be homeless health care and other issues related to the homeless issue, which is a major problem in this country. We have two special guests. Bob Wojda is a physician who works at the Family Health Clinic Center at the Phoenix Clinic on Muhammad Ali, not far from University Hospital, and nurse practitioner Teresa Casey, who has worked for this organization for many years and does outreach, which I think is just a remarkable activity of visiting his homeless camps. And also, as I understand it, runs the respite unit. So Bob and Teresa, thank you both for coming on the program. This is an important issue, and it's a real issue for this country. So we're looking forward to your remarks and learning some more about the homeless situation here in Louisville. As we've done with our guests in the past, and when we had you on about a year ago, we're going to give you both an opportunity to make whatever comments you'd like to make for as long as you'd like to make them. And then Jean will begin with the first question. So Teresa, ladies first, we'll let you make whatever comments you'd like to make. Would you explain the respite unit for us, for our listeners, please? And then Bob, you're next.
Our medical respite unit is for people who have acute medical needs, such as post-surgical healing, wound care, maybe exacerbation of a chronic illness such as COPD. They've got pneumonia, some issue of that, dialysis, people who start dialysis. We also have people who are receiving different therapies for cancer. And also antibiotic infusion. Now, in our unit, we do not provide those particular procedures. We provide a place for people to have a room, bathroom, food, social services, but they must be able to care for themselves because our funding does not allow for us to provide medical care. So we work on transportation to help them get where they need to be for their treatments or their therapies. We are very limited. We have 21 beds, and then we split between male and female, and we are also in Hotel Louisville, which is part of the Wayside Shelter. So we must abide by those rules of the shelter, which are sometimes restricted for our patients. It is an abstinence-only building, and it's also People cannot be sex offenders. They can't be barred from the shelter for any reason. Let's say they got in a fight with somebody at the shelter. Now they're banned from the shelter, so they cannot come into respite. So this creates a lot of issues for us with people who really need respite care, but we cannot house them either because we don't have the ongoing medical people there. We have a nurse practitioner who staffs 4 days a week, but she's not there 24/7, obviously. And we don't have medical assistants or other nurses to provide wound care or any other type of care for people after hours. We just have peer support and social workers. So it really limits what we can do for people. You know, it's a good place. It helps a certain number, but we can't manage all of the people who need medical respite care in this city.
Well, thank you.
And otherwise they would be homeless.
Yeah, thank you for explaining that. Bob, it's your turn. Whatever comments you'd like to make about the homeless situation, maybe you could just comment on how different it is from a year or so ago when you both were on, if it's changed at all.
Well, thank you for having us. The number of homeless has grown. There's a website that is run by the Coalition for the Homeless, and they track year to year, month to month, basically how many people are going in and out of homelessness, how many people get housed, and they basically have this dashboard, and you can see how it's increased over a number of years. The pandemic certainly didn't help at all. And despite new administration and everything, it takes time to, it really takes time to do something with these people. Temporarily, there's been things that have happened, but despite increase in providing shelters, increase in housing people, the number of homelessness has gone up about 139% this year, which is a lot. It's a lot, and people come. They're not just homeless people who are living here in Louisville becoming homeless, but they're coming from other communities because they hear better stories, and that's probably true. From what I hear, people come from Indiana, from Virginia, from Ohio. So here we are, and we do our best to try and provide some health care for them, and often they're complicated patients. Sometimes it's easy, but sometimes it's very difficult because they have multiple medical problems and they've just kind of up and left, and here they are. Among them, probably the most difficult are the people who have schizophrenia. Often don't want to be medicated, and they're way out there. So here we are.
Okay, well, thank you. Gene, you want to begin?
Well, let me ask, who are the homeless and why are they homeless?
If you look at any of the, like Kentucky League for Cities, there's a number of national coalitions. All of the resources will say the number one reason that people are homeless is because there is a huge lack of affordable housing. We know in Kentucky that we are short close to 100,000 affordable units. We're looking at people who maybe, we've seen people who are housed and then they have to have surgery and they lose their housing because they couldn't pay their rent because they were in the hospital. People who've had fleeing domestic violence, people who lost a partner. We see a lot of elderly people here. I would say probably close to half of our patients or even more over 60.
That's true.
And they have various reasons they've not been able to maintain their housing. I mean, we could tell you lots of stories on why people have lost their housing who were formerly housed and safe. And at Phoenix, we believe that housing is healthcare. If you are not in a housed situation, you are not able to maintain your health for obvious reasons. And if you are unhealthy, you are more likely to lose your housing than someone who is healthy. We also see people who, it's a combination of the fact that rents have increased. Uh, the average rent here in Louisville right now has gone from about $750 to $1,000. I saw a person who was homeless not too long ago who said his rent went up exponentially, and so he had to pay child support or pay rent. So now he's living in a camp because he has too many bills to be able to afford rent. Many of these people are elderly people. Most of them are on some kind of disability or Social Security, so they don't qualify for some of the same types of assistance as other people do. They can get subsidized housing, but they go on a waiting list that's months long. So they end up staying in shelters, and some of them do live in camps as well. And then obviously we've got the substance use, people with mental illness and substance use. And that's really difficult to capture, but my thought on that is it's more people than not, because even if you did not have a mental health issue, once you become homeless, your things exacerbate very quickly. And if nothing else, you have PTSD from the trauma of becoming homeless and having to live in a different manner and not knowing how to do that. Some of us might survive for a little while. Bob and I could probably go live in a tent somewhere for a little while, but at my age, I wouldn't manage for very long, very well. And so then you take people who don't have the basic life skills to over these humps, and it just throws them in chaos and homelessness.
Yeah, I may add to that there was one study done in USA that showed about a third of males and females are homeless, had really serious psychiatric problems. And, we all remember the 60s and the 70s where people with serious mental illnesses basically became institutionalized and were basically taken off the streets, taken away from families that maybe were caring for them, and they were in the institutions. And then came along, I guess it wasn't just a Republican thing, but kind of a Democratic thing, that people should be allowed to choose where they live, and they set up all these halfway houses for the mentally ill. And that was all okay as long as it was funded. And once the funding kind of ran out, there was nowhere else to go. There's an interesting book right now out was recently published by an author named Tracy Kidder. It's on the New York Times bestseller list. It's a biography of a Dr. James O'Connell in Boston, who basically runs their healthcare for homeless. He started doing it in 1985. And Tracy Kidder drives around Boston with Dr. O'Connell, and he points out the gentrification that's taken place. You had a lot of neighborhoods where people could rent a room for not much money, and these were, people who came back, veterans who came back from war and didn't have a place to go, elderly people on a very fixed income. They could, rent at least a room, maybe share a kitchen, maybe share a bathroom, and get by. At least they weren't on the streets anymore. That's impossible to do these days. We have a lot of clients who live in their vans that are nearly broken down, or their cars, and are leery of the shelters because they're worried about getting robbed or catching diseases. So they kind of,
violence.
The violence is a big issue for homeless as well. They're probably 10 times more likely to be beaten up or murdered than your average person who housed, even in bad neighborhoods. So,
well, should we go back to reinstitutionalizing these patients?
Well, good question. A lot of people would argue yes, at least some of them, because what kind of choice does somebody who's severely mentally ill really have? Or do we have to institutionalize them? Do we get them caseworkers? Do we set them up in halfway houses somewhere where they actually are getting some kind of care? Or do we just let them wander the streets? Unfortunately, right now we're just sort of letting them wander the streets. If they do get admitted to a psychiatric facility, most likely Peace Hospital or in the Norton system, they last 4 or 5 days, and then the insurance says, well, that's it, you're out, and they get discharged, sent to our clinic to get their medications, and they end up either at Wayside Christian Mission or Recenter Ministries or St. Vincent de Paul, all these places who provide a patchwork of places for the homeless to stay. And as long as they're taking medicine, they might be okay, but they really have a tough time functioning in 21st century society. They would probably have a difficult time functioning in 17th century.
We had Pat Murphy on last Friday, who runs the Murphy Pain Clinic in New Albany. And one of the things we talked about was the influence of the fentanyl that is not so much the drug fentanyl, but the way he called it was the chemical fentanyl. It was made in China and is delivered to the cartels in Mexico, and then that is put in an assortment of substances and ends up on the streets here, and which has really been a big issue. So, from a standpoint of overdoses and addiction, how much of an issue, or is that an issue at all, in your experience with the increase in the homeless between now and the last time we talked with you about a year or so ago?
It's a huge issue, the addiction, and it's not always the illegal drugs. Alcohol and tobacco are still major killers. And sometimes you'll ask a homeless patient, well, how old were you when you started drinking? And they say maybe 4 years old, maybe 5. Would say, go get me a beer out of the refrigerator, and they would start taking a few sips, and that was another 50 or 60 years old and have cirrhosis. And it's the illegal and the legal drugs are quite a problem.
Yes,
And we definitely, I'm sorry, we do see more overdoses because of the fentanyl, and we see people who are getting drugs that they think, for instance, that they're getting meth, but it actually has fentanyl in it. So then they end up with an overdose, and intentionally, we see more of that now. One of the positive things that our legislature has done recently is to declassify the fentanyl strips so that they're not considered paraphernalia. So if somebody wants to be safe, they're using, they can't stop, they don't have resources, whatever the case is, they have test strips so they can make sure that their supply is not contaminated, or what do they have in this drug that they bought. Not advocating necessarily for that, but we have to do what we can to keep people safe until we can help them live a different life,
What about the new IM injections that last several months for people with schizophrenia, bipolar? Has that made a difference? And so we know that people are getting their medicine, that we don't have to depend on them taking a pill every day?
For the people who will take them, yes.
Yeah.
And if they're accessing care where they can get the medication and then the insurance will cover it, and they actually take their meds, yes, it does make a difference. We have one client here who's she was on a 1-month shot and now was transitioned to 3 months. And I did not see her before she was on the injectable meds, but they said she used to come in here and tear the clinic down, and now she's very stable. She, still has schizophrenia. She still has some problems with that, but she maintains all of her appointments. She takes all of her medicine. She's able to remain housed. So yes, absolutely, it does make a difference if people will take the injection. But a lot of these folks are paranoid, have paranoid schizophrenia, and that it takes a while to help them understand that this is going to be good for them as opposed to something that, could be harmful because you're shooting something into their body that they are worried about. It's just part of the disease process.
Yeah, at some of the camps that we go to, people won't even give their names to us. They're so paranoid they'll give their nickname, but that's about it. They won't give us a social security number or anything else. We can't really get them medication because there's no way to really do that if we don't have a name and some kind of a identification for them.
Tell us a little bit about the camp issue, if you would, Teresa. I guess you visit these places, and they seem to be moving around a lot. Can you kind of give us an idea of how this works? I mean, I remember driving down Jefferson Street, and there'd be a bunch of these folks under the underpasses, and they're all gone. And I'm also for
now.
Yeah, that's temporary.
Well, they're not good. They're gone from there. I didn't say they're gone.
Right.
But also, we drive down Lexington Road, and once you got past the Lexington Grinstead intersection, on the right-hand side of the road between 64 and the Lexington Road was another huge camp, and that's gone as well. So, if one kind of give us an idea of how they get moved, and if you could, where have they gone?
Well, Bob and I both do outreach, but I've been doing it a little longer. And it's a very difficult situation. We have trouble finding people in camps now because you're right, they're scattered. And there are a couple of different ways it happens. The city has a group called Resilience and Community Services, and those people go around and try to identify the causes. What are the barriers? Why are these people not being housed? What's going on with them? And if there's a camp area that's deemed a safety problem for either people around or the people who are in the camp, or a sanitation issue, then they give them a 21-day notice to clear. You've got 21 days to find where you're going. And now they communicate with us, with our case managers, to say, we're going to clear this camp in 3 weeks. Can you go see what can be done for these people? Now, there are other camps that end up on state property. For instance, there were people camping along the fence on Preston Highway, pretty close to the 264 interchange. That is state property. So those people get no notice. The state says we're clearing it on Monday, and so then they have to go somewhere. If the city clears a camp, some of those people may be housed. There is some funding. They may put them in a hotel for about a week and give them a break and time to regroup and see if we can get them processed somewhere. After that, they turn them out of the hotel and they end up just going back where they came from or find some other place to camp. But then the case managers don't know where they are, and we spend a lot of time looking for where people have ended up because we've started a housing process. I went to one of the hotels and I had started people on medication and different processes. Now they're gone. We don't know where they are. We can't help them get what they need. When the state clears, it's just leave. And in both cases, they bring sanitation in, sometimes backhoes, and they just scoop up everything and throw it away. So if people are not able to get their belongings out before this happens, they lose everything. So our patients, sometimes they lose their medicines. That happened not too long ago when someone got cleared. His medicines were gone, so we had to reissue his inhalers for COPD. So it seems to be more, it's happening more than it was. And I think during COVID, people got used to kind of being in one place because they had nowhere to put people, so they just left them where they were. but now they're clearing a lot. Sometimes it happens because they're along the railroads. Yes, has their own police and their own clearing. If they're on the Beargrass Creek waterway, like what you saw there at Lexington Road, those are going to be priority places to clear because of the sanitation issues. And then one huge camp that we had, Mercer Camp, has been cleared because that's where the new waterfront park the waterfront park is doing their expansion down there. And that property was co-owned by the city, Mercer Transportation, CSX. CSX and cleared their area a couple years ago. So there's a lot of things at play in terms of where the people are. Sometimes we don't even know anymore.
Yeah, we don't know where all those people from Mercer went to.
Yeah.
A lot of them were our patients, and that was around 10th and 11th Street, right by the river. You know, you'd be at the camp and you'd see the barges going by and people cooking things and, yeah, burning plastic off of wires and everything, because a lot of people recycle metals and everything so they can get money for them.
The city developed a safe camp called Hope Village, and it housed 45 people. And the thought was, we're going to take people who who want to be housed in camps here, get them social services, and then get them moved into housing. Similar to things that are done, like in Austin, Texas, has a huge place that's about 110, but it's managed by a group. And unfortunately, to get in Hope Village, you have to meet certain criteria. You have to be referred. You have to be vetted, and then most of the people have been there, some of them 7 months to a year, because there's nowhere for them to go. There's just not the house to move them into for various reasons. And there been issues some of the social services there, but we definitely don't have enough space. A lot of people don't want to go into the shelters because of the things that Bob talked about before. Yeah.
I got a few of my patients. Go ahead.
Is the city and state government trying to do something better or different to try to take care of these people?
Well, since Mayor Greenberg office had a kind of a $30 million plan to prevent or even homelessness in Louisville. I think $8.25 million were going to go for prevention services, and that's, you know, $4 million to create permanent affordable housing, and they purchased some land where they're going to build a community care for continuation of care, and have a respite unit there as well for people who are transitioning from hospital to housing. Burns Hospital and UofL have sort of been involved in that as well, because I think they're frustrated and overwhelmed with the amount of homeless that end up in their emergency rooms. And our patients, you know, who come here during the daytime, go to the ERs at night, because those are the default hours. Those hours at 4, and we don't have any nightclub or anything like that. So somebody runs into a problem, gets high, gets drunk, falls down, they end up in an ER.
You know, another problem that the hospitals face is that many of the people they discharge really need a subacute rehab placement, and there aren't enough of those facilities. And sometimes they won't take them because of the payer mix. We can't get home health for people because home health has a certain number of Medicaid, certain number of Medicare, and if they've reached their Medicaid limit, then they won't take the patients on. So our medical respite unit is where they try to send these folks, but some of them are way too complicated, have too many medical needs, wound vacs and continuing infusions and different things to be able to come to our respite facility. So they new facility provide a medical respite that is more like a subacute rehab or has more services available. Um, and you know, unfortunately, when they have people like that, sometimes they just end up on the street anyway. It's a very sad situation. And Bob
Now,
can tell you a lot of people he's dealt with that's happened.
let me ask you about your opinion about how the not-for-profit health. Uh, we've got three health systems: U of L, Baptist, and Norton's. They're all not-for-profit. They all have a special tax status, and they're supposed to devote a certain amount of their activity to take care of people who are in situations like this. Give us a view. I mean, you obviously must deal with all three of them. How well are they meeting their responsibility to justify their special tax status of being not-for-profits and spending? I don't know enough about the details, but they're supposed to devote a certain amount of their activity to taking care of people like the homeless. Can you give us a kind of an overview of how well they're meeting this responsibility or not, and maybe whether one is better than the other?
Well, the other day I visited some of my homeless patients, and I went to three different hospitals. One was Jewish hospital, where a patient who had uncontrollable seizures was getting a deep brain stimulator implanted, and he was treated extremely well on the neuro ICU. He was very happy there and did well following his surgery. Another patient is unfortunately in dire straits and probably terminal, but he's being treated at Norton Hospital. And they were very, very good to him. And unfortunately, he's just so sick, he's probably going to pass. And they really didn't spare any care at all. And then another patient was at University Hospital. He was also treated very, very well. So, I mean, I can't complain. I mean, I was an ER doc for 30 years, and I know that in the ER sometimes they don't get treated with the same compassion as others, especially if they're high or drunk and disorderly. But in general, I'm pretty amazed at how well some of my patients have been treated here at the hospital.
I'm
So
really glad to
I
hear
think I
that.
think that yeah I think it's the problem is not so much the hospitals, because they have good people working there. Their heart's in the right place. I think deal with insurance companies is a problem as well. As for certain disease, you get X number of days paid, and otherwise, you got to hurry up and get that patient out of the hospital if you can.
And
So,
that's what I see is that if these people have been there X number of time, it's about moving them out, not how can we continue to take care of them. And that is insurance driven. So are they taking care of people for their nonprofit status? I'm not sure. When I worked at Ephraim McDowell Hospital, I was in community services, part of my role there, and we had to provide certain amount of community benefit to show on the purposes to maintain a nonprofit. And some of the things we did for that were more like what you see Norton doing, which is community health screenings and doing this thing in the community and that. That's where how they manage their nonprofit status. With that, yes, they're supposed to provide a certain amount of indigent care, and I'm sure they do write off some care, but I think, as Bob said, the insurance really drives how long someone's in the hospital, and you may still be sick when they send you out, and you know that from your own experiences, I'm sure. That there are people you really think aren't ready to go, but the insurance isn't going to pay one more day and they end up being discharged.
As you know, I'm from a rural area, and how do we deal with the homeless in the rural areas? And have y'all had any experience with that?
When I was practicing in Danville, I lived in Mercer County for 23 years and practiced at Ephraim McDowell. We had a free clinic called Hope Clinic, and this was before Medicaid. And I managed that clinic. It was a disease management clinic. If you have one of the 5 top players, hypertension, diabetes, obesity, that kind of thing, then we would screen people and take them into our clinic. And that we had a number of community partners, and we were able to get medications and lab work and whatever people needed. Part of that stemmed from the fact that they were frequent ER flyers, and the hospital viewed that as part of it. Also was community benefit, and that we knew people weren't getting health care. It was very difficult to vet who was truly homeless, because in the rural areas they tend to hide that, and they tend to kind of ignore that there are homeless people sometimes. Some communities don't want to acknowledge that, or the homeless people they find abandoned houses, abandoned places. They're just not as visible. But I recently was working with a researcher at U of K, and in part of the research, they also interviewed individuals groups in rural areas, and how rural areas manage homeless people is very different. Again, because of the recognition, they don't have the resources. So we see people here in Louisville that are from those areas. They leave because they can't get here and they can't get the things that they need. We have an addiction MOUD MAP program here, and 3 of the patients I have on that are from Eastern Kentucky. They said they came to Louisville, but they couldn't do anything. They couldn't get jobs. They couldn't get help. They, couldn't get health care, so they came to Louisville. So I think, unfortunately, that's how some places manage. I recently read an article about Alaska has about 3,000 homeless people, and the mayor is wanting to buy plane tickets and send them anywhere they want to go just to get them out of Alaska. And I don't know that actually actively happens in rural areas, but we know that people come here from Virginia, from Indiana, from rural Kentucky, because they can't better themselves. They can't get housing. They can't get jobs. So they move.
And for your listeners that don't know what an MT program is, it's medically assisted treatment. So somebody with an opioid addiction can get Suboxone from one of us here. And we have lots of rules, a contract that needs to be signed, drug screening, counseling, all that kind of stuff that has to go along with that. And we try to get folks who have the opioid addiction on an injectable Suboxone so that they don't have the cravings, and also so that none of their medication gets diverted or sold on the streets, because that's a certain way people will make money. They'll get their medications for whatever and then sell them on the streets. So
Now, I've got a question that may not be a fair question for either one of you, but I'm going to ask it anyway, to see what your thoughts are, or what experience you might have with dealing with homeless people in other countries. It's my impression, which may or may not be correct, that in many European countries who have much stronger social service environments that people live in, this is not as much of an issue. Could you share whatever thoughts you might have about this? And I understand that this may not be a fair question, but I thought I'd ask it anyway.
well, I go to Poland fairly frequently, once a year, once every couple of years, and they have issues there, and it's the same issues that we have here. It's the mental health, the keeping people on their medications when they don't want to take them anymore. They can't really force them to do so. Maybe they can keep them longer in the hospital to get them more stable, but once they're out, they tend to start wandering around the cities and the countryside, and they have their problems with alcohol and other addictions as well. So it's similar. The safety net might be a little bit better, but I think it's about the same. I've been to Stockholm, and my wife and I walked all around Stockholm looking for one homeless person. We never did find one. And we went far away from the tourist areas. We went into the working class neighborhoods, and we just didn't see them. And talking to people who work there, it says, well, they've got good mental health services. But that's a much smaller country and has a tradition of providing good health care to their citizens. And they pay for it, but they seem to be happy with the results as well, at least the folks that I've talked to. So my evidence is anecdotal. I don't have statistics, but I know that, historically, there's always been problems during 17th, 18th century. The British would send their what they would call their vagrants, which were people who basically were homeless, and their criminals to the colonies, because that was a convenient way to get rid of them, get them off the streets in Britain. So, yeah, they have issues still. They can't send them to the colonies anymore. Yeah.
Mine, like
Jean?
Bob, is just anecdotal. Been to um, Europe, several different places in Europe, Ireland, Scotland, France, Germany. I've seen the scattered homeless people, but not encampments and things like we have here. And I have also seen more safety net, like missions, ministries, things, which I guess would be like our shelters, but they seem to be a little more comprehensive than what we have in our shelter system here. More social services and health care for people.
As
I
any,
would like to make
go
one
ahead.
comment is that in the homeless people we see here, very few of them, very few, are um, foreign, foreign-born or immigrants. These communities house each other and take care of each other. We have a few Spanish speakers, a few African um, people, but for the most part, people who are not, um, born here in America are not people that we're serving in the homeless arena.
Well, that's a really interesting observation.
Yes, why do you think the refugees here in Louisville are not involved in being homeless?
I think that we have a good refugee management community. We have the Catholic Charities, there's Highland Refugee Ministries, there's a group that works at Americana out on the South Side. So there's an engagement for those folks, but they also have a different sense of community. They may, they don't think twice to put 12 or 14 people in a house. And
It's a very tightly knit
yes.
community.
Yes. And that's like I said, for the most part, they kind of take care of each other. And, but I do think that they have a pretty good safety net. And we have one of our clinics at Family Health Center at Americana is pretty exclusive for immigrant and refugee screening and care. And they have people groups. Gosh, I don't know how many people groups they serve. Lots and lots of different ones.
Can you break down a kind of, again, in an overview situation, the kind of insurance status of a homeless population? And again, I know this is kind of an unfair question with all the issues you've talked about, but you've got Medicare, you've got Medicaid, got private insurance and uninsured. Could you kind of give us a sense of, out of 100%, how many would fit into each of those groups?
Prior to the Affordable Care Act, I think the statistics were maybe 15 or 18% of our patients had any kind of health insurance at all, and that was primarily Medicaid.
Right.
Medicare. That was primarily Medicare. And since the Affordable Care Act took hold, we've been very active in signing people up for insurance, and so have other places. And so I think it's probably around 85% now folks have insurance. And that's important because if you have a hernia, if you have a knee that needs surgery or specialist care, you can send somebody who has Medicaid to a specialist and they will get taken care of. We have dentistry in our clinic. But even if you have Medicaid, we can't find you an oral surgeon. You'll have to go to see the university, the residence for oral surgery, because no private oral surgeon will see anybody with Medicaid. So those are kind of issues, minor issues, but things that are important on a patient-to-patient basis. And even now, after the pandemic, a lot of people are losing their Medicaid. So we have a person who works as a connector here in our clinic, and she checks people's insurance status and tries to get them signed back up for it. And without that, most of our patients would be in dire straits.
Our patients that are on disability have Medicare, and prior to Affordable Care Act, once you're awarded disability, you get your disability income, but you don't get medical care for 2 years. And so the Affordable Care Act really helped stem that gap for people, because a lot of the folks in my free clinic were on disability but had no insurance. And so now they qualify for Medicaid. And when they get their Medicare for disability, they can also, depending upon what their disability income is, usually they can kind of stay with the Medicaid or a different form of the Medicare Part D that's covered by QMB. And so that's been just a wonderful help for people in terms of, being insured, being able to access medical care. So we've seen a lot of the free clinics in the nation have gone by the wayside. We still have one active free clinic here in Louisville, and they are in the Butchertown area and treat mostly Hispanics, undocumented people who can't get insurance.
We're one of our goals here is to have a single payer system, Medicare for all. And I'm assuming, again, asking your views about how much difference this would make if we had, Gene and I are both realistic about the unlikelihood of anything like this happening anytime soon. But if we should get to a point where we have a single payer Medicare for all system, I'm assuming that would make both of your jobs a whole lot easier in terms of dealing with your homeless population.
Unless you got all the insurance companies fighting for Medicare replacement plan money, which
Right.
it's it's a pipe dream. I just don't see it.
And I think we're fortunate in Kentucky that we do have good medical coverage for people. And I worry, term to term, whether our legislature, what will happen with that. But it's definitely, I think, kept people healthier. But I know in so many other states, they don't have the kind of coverage that we have. And if everyone had medical care, Medicare for all, then maybe we wouldn't have so many people shipped from out of state to here. They would be more stable. They would be able to access their health care in a different way.
You'd have to include dental,
Right.
because people need teeth. for good health.
And vision and hearing. My goodness, we know that one of the number one causes or, you know, complicators of dementia is hearing loss. You know, you can't hear, you're not making connections. So there are a lot of things that our current medical coverage just doesn't cover that are kind of basics in our lives to be able to function. You have to be able to see and hear and chew, right?
Now, I'm going to ask you another question that may not be a fair question. Do you have a sense of what percentage of homeless people actually work their way out of this back to some sort of normal, reasonable living conditions?
I can't give you a percentage. People's reasons for being homeless are very individual. And I think the folks who have their wits about them, who are resourceful and don't have an addiction, are much more likely to get housed and get housed fairly quickly. I've seen elderly people who have fallen on tough times because they've lost all family support, whether it's through divorce or illness or poor planning or um, losing their livelihood and not being able to make ends meet with Social Security. But we've helped several get housing, and we've taken care of their medical stuff. And once they get housed, they have about 6 months grace period where they can still keep seeing us before they move on to a different organization, different primary care. I've had some good success with some folks, and the ones that are mentally ill, they get housed, and they, despite having support services, they can't handle it. They don't pay their bills. They get evicted for drug use or alcohol or throwing parties in their place and inviting people in who shouldn't be there. It's a real mixed bag, and I can't give you a percentage, and I don't think we even keep statistics like that.
People who are housed through permanent supportive housing programs, there's a lot of different kinds of housing programs, and the PSH program, which is what we run through our clinic, is one that assigns case managers to people, and those people are more likely to remain stable in housing, possibly be able to get jobs where they can contribute more to their housing, but the case managers make sure that they're making appointments and getting their medications and that they're doing what they need to do to stay in their housing. I think some of the other housing programs, for instance, Goodwill has an excellent program. It's called Second Chance Services, and they help people with housing, but they also give them job training. They get them put to work. They help them expunge records. If they are felons, they get them what's called a second chance job, because there are a lot of employers that will not hire anyone that has any kind of record. So they have certain employers they work with that are willing to give someone a second chance, so to speak. So when they're housed, those kinds of programs, again, there's a lot of resources to help them find gainful employment of some kind. And Goodwill also has not just a GED, but they have an adult high school now. So when people go through those types of programs, they're stable, they're able to get jobs. People who were previously employed very often will go back to work, but like Bob said, there's a large percentage too that need housing just to be stable, but are not capable. They just don't have the skills to apply to normal daily living like the rest of us would think of.
Let me give you a quick 5-minute warning here. We're getting toward the end. We've got about 4 or 5 minutes left. Gene's going to ask a question. I've got another question, and then probably Mark is going to take us out.
Do you get grants from the state and federal government, and do you also get money from non-for-profits and even for-profits to help you run your clinic?
This clinic is almost total grant funded. Our clinic director spends almost all of the time in finding, writing, pursuing grants for the various services that we provide here. We are part of federally healthcare center, so we have some funding from community block grants at the federal level. We get a little bit of state and a little bit of city money, but not very much. We originated as the health department system a long time ago, so that's how we kind of have a connection to the city in terms of funding. We don't get funding necessarily much from nonprofits, but I will tell you that the nonprofits in the city are a huge piece of helping the homeless. There's a lot of them. Feeding Louisville, Forgotten Louisville, South End Street Angels, and I could tell you just time after time what they've done to help people become successful. And they really are probably the most active group, other than whatever we do here at the clinic, active groups in helping people survive on the street, and in many cases get housing as well.
Yeah, there's about 30 members in the Coalition for the Homeless. Everybody from Center for Accessible Living, Boys and Girls Haven, Houses of Hope, all sorts of places. House of Ruth is St. Vincent de Paul, St. John Center
guys,
right next door to us.
I want to thank you both for coming on here and talking to us about these important issues. And I also want to thank you both for the humanitarian activities that you're doing. And I'm not a religious person, but I hope you both got a special gateway to heaven for what your activities are. We're about done here. Mark is going to take us out. Thank you again.
Michael, I just have to say, if you want to think about heaven and hell, go to heaven for the climate, you go to hell for the company. That's a more Plainism. Okay.
That's a good way to close it out.
Okay, that's a very unique way of closing one of our shows. Again, I join Mike and thank you guys for your work and for coming on. I'd also like to thank everyone who turned out to the Medicare birthday party we had this past Sunday over at the public library. Paul Hoppy, who purchased the film for us to see, and his niece, who baked the cupcakes for everyone. For more information about Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org, kyhealthcare.org. Kay Tillo is our chairperson. You can reach out to Kay at nursenpo.com, nursenpo@aol.com, nursenpo@aol.com. And for Single Payer Radio, my name is Mark McKinley. Thanks for listening.
Thank you.